It's my pleasure to welcome Dr. Missiani Ochwoto, who's a senior research scientist at the Kenya Medical Research Institute. Please, Missiani.
Thank you for the introduction, and I'm going to share the insights on scaling up screening and antenatal care in Kenya, and also the outcome of what we have. I do not have something to disclose. Let me start by this call for action. And when I was in grade 10, a friend of mine lost one of the relatives, and that was the sister. And during this time, what happened is the sister was married. She was divorced because of being sickly, and then she had extended stomach. And when she died, she was buried at the parents' home. Thereafter, a few years later, we came to learn that she had hepatitis B. And 2 years later, the two sons died. What am I saying? Hepatitis B wiped out an entire generation of that family. And if these ANC programs, which I'm going to share with you, were there during such a time, that could be averted. What is this hepatitis B? It is a very small virus, which is a DNA, and it infects the liver. And it has two outcomes, self-limited and also chronic. For those who extend to chronic, 10% of the adults and up to 95% of the children, they develop cirrhosis and death. In terms of global, 254 people globally are infected chronically. And each year we do have between 800,000 and 1.2 million deaths, including that of my friend who died that time. 1.2 million of new cases each year are reported, and hepatitis B is actually the cause of premature death. Globally, if you look at the distribution, I know this will be shared again and again. Africa and Western Pacific have the biggest share of that. In terms of Kenya, we do have it at 3.5% as prevalence, and that is translated to 1.1 million. In some regions in the country, especially where we come from and other places, the prevalence is quite high, up to 7.6. We have done a number of studies, especially on pregnant women. This started some years back in 2016, where we did it in the capital city, that is in Nairobi. And the prevalence by that time, it was 3.8. But we also experienced limited access to hepatitis B test as a main barrier, awareness and stigma, and also vaccination gaps, which many people didn't know about the vaccination, especially of those who are positive. We repeated this in 2019. This time around, we treated the mothers who were positive and introduced birth doses. And we had 1.1, which was the prevalence then. But the main thing which we really accomplished by that time is that all the children who were born of positive mothers were vaccinated, and we averted that 3 possible hepatocellular carcinoma. What that taught us is that the main barrier for quality testing was limited access to test kits and reagents. This was main. Fragmented testing points in the various places in the lab at the ANC, and getting the results took a long time. And in some facilities, they were not able to test hepatitis B, so they referred these people to other places. I'm going to talk of these 4 and how we tried as much as possible to increase testing in those areas by looking at those barriers. We did this using a multiplex and a multiplex approach in rural areas, actually rural facilities and the primary healthcare in these areas here, which were southern part of Kenya. And the tests which we used, it was a prototype which was provided by Abbott. This prototype had the 4 diseases, test for 4 diseases, that is HIV, syphilis, hepatitis, and malaria. Remember, malaria is not part of the triple elimination. And this test used only 1 finger prick. And through that 1 finger prick, the blood will be sprayed here. You have 1 here, you have a drop here, and all this. And you wait for 15 minutes for you to get the results. We integrated this process into the primary healthcare services, and therefore that was very seamless. And whatever at the healthcare was done, we integrated to that, especially the HIV program. And we started by training. In the training, we train the nurses, not necessarily on how to use our RTK, but on how to do the test and test the disparities and how to improve the outcome. What we realized is that they were competent and they could use the RTKs very well. When we asked for their perception, 90% of them gave it 5 out of 5. And that means it was excellent. And the reasons why they did so is effectiveness, and it was accurate. It saved time and it minimized the movements. Some of them cited early detection, especially for the HIV, because it had a P24. What we did is we did up to 577 women, especially those who are coming to the second test. And we confirmed the results of them or what was indicated in their book, which is the ANC book. And we tested them using the panel, which was the 4 ANC panels. And we digitalized this, and I'm going to talk about the digitalization and how important it was. We gave them the results, and we assessed also their experience. What we realized is that hepatitis actually has a high opportunity. That opportunity is up to 99.3. This is because by the second visit, all 99.3 mothers already have been tested using RTK. And that tells you how important it is, especially those who are doing it within the facility and those who can be referred. But the main thing is that we have a huge opportunity, especially for hepatitis B, to introduce this at the ANC and have very high results. Of the tests that were done, most of them had 2 or 3, and very few had up to 4 tests. Of those 2 and 3 tests were actually HIV, syphilis, and malaria. Hepatitis was very low in terms of that testing. That means that if we introduce this at the ANC, we are able to get 80.5% of those who have never been tested. The distribution wasn't even because some of the facilities had very high tests at that particular point. What lessons do we learn? I'm going to take through around 5 or 6 lessons that we learned. The first one is that by using a multiplex test, we actually increase the availability of tests to those facilities because 80% of them said shortage of reagent and stockout was the main barrier of them testing. And that means that by introducing a test that can do up to 4 or up to 3 tests, will make it available, and that will break that barrier. The other barrier was about the workflow. Mother will come to the facility, she waits for her turn, she goes to the ANC, test in the lab, go to test in the lab, wait for the results before going home. But in this multiplex, you realize the mother will come and wait, go to the ANC or the lab, test all the 4, and then she goes home. That saves time. And not only that, the where and when to test. That really improved because even if it's coming to second or third visit, she will be able to be tested quickly and go home. The other thing is on management of time. That was well done because this test will take a very short time. It saves actually up to 66.3 of the mother's time. And remember, where we were doing this was a primary healthcare, and 5 of 8 of them had only 1 nurse in the whole facility. Saving time will really save and increase the number of people who are tested at that time. Referring, it actually completely reduced the referral. I want to take some time on data consolidation because this is very important. Why? Because by collecting data from the 4, we improve the disease management, both for the patient and also for the care provider. So the patient will get the data, the patient will know, or the patient will be addressed at that point. And looking at the goals of the triple elimination, this actually harmonizes so well with the triple elimination. Why? Because it improves the consolidation of data and minimizes any data missing. In competency, we do know the competence of the kit, and that will also increase that and the accuracy of that. If this data is translated into the national system, it will help in timely decision. So integrating and making sure that we have all the 4 data was really a major improvement in terms of the testing. Let me take you slightly outside the data collection and how to manage the data. For us, we only did data for testing and linkage. Those are the things that we improved and digitalized. However, we do have opportunity of using this multiplex also to go to building capacity and also management, care and management, and especially the birth doses, because this will help you in tracking those who are positive and those who have been given the birth doses. So there is an opportunity, especially of digitalizing the data that is collected from this. Let me look at the the affordability of this ANC. We asked them who meets the costs, especially the travel costs and also for the facility. Majority of them being in rural areas, this was expected, that male are the one who took care of that. However, some of them were able to do it by themselves. I want to draw you to the attention of those who said the parents. These were actually the adolescents and those who had early pregnancies. We will like that the programs that are reset, they will also take care of this, because this group here is actually fragile and not many of them will make all the visits to the facility. And looking at it, most of them actually didn't have the insurance, and therefore the insurance component in terms of meeting the cost in some places may not be feasible. And the cost we looked at, was there any cost benefit by using a 4 test and HBsAg using 1? Yes, there was. To the facility, especially the health facility, it will actually help save 47.4 of the facility. This goes to the consumables and overheads, and especially knowing that this is only 1 finger prick for it to test all the 4. And for the mother, it actually improved, not necessarily on the distance, but it will save in terms of the time that is spent. It will save by 9.5. In fact, when we gave these results, one of the mothers was excited, and this is what she said: "This is a game changer, for I will not waste time to follow up my results again." Let me conclude by saying this, that using a multiplex is really a good approach, and it will scale up the testing, and more so for the hepatitis B, which is lagging behind, and it will improve the access to the facility. And integration is a way to go. For us, we integrated using HIV. However, there are other platforms that can be integrated for us to improve the access and improve the testing at the ANC. Other things which can be done is we do have the capacity, and most of the facilities have been testing this using the RTKs. So the capacity is there, and then it is good for us to capitalize on that capacity. I would like to thank the people who did this with us, Micah, Damaris, and Evans, for their support, and also the facilities and institutions that were involved in this, and also the people who did it, the AMREF, the KEMRI, NASCOP, and other stakeholders for this. More importantly, I would also like to thank the Abbott research team for what they did to us and how they improved the tests that we did. On that, I would like to say thank you very much. Asante sana, Masi. Any question, I'll be able to